So we'll talk about the digestive system. This will just be one lecture to talk about the different sections of the digestive system, as well as some of the histology of the digestive system. Most of what you need to learn about the function we'll talk about in physiology, but we will talk about just a little bit of the function as we go along. So if you think of the digestive system, really we're talking about the entire length of the system from the mouth to the anus. And if you think about it, it's really just one long tube that food and other things that we ingest come in the mouth and eventually make their way out through the anus. So we have several parts of the digestive system along the way to look at. We'll look at the mouth and the throat, and then we'll move into the esophagus. From the esophagus, we'll hit the stomach, then we'll do the small intestines, and then the large intestines, ending with the rectum and anus. As we go along and we talk about the digestive tract, we will also introduce some accessory organs. These are organs that are involved in digestion, though they may have other functions as well. And since they're not technically part of that one long tube, we talk about them separately as accessory organs. Those will be things like our teeth, tongue, and glands. We'll also talk about the liver, the gallbladder, and the pancreas. All right, so as we were talking previously about the respiratory system, we wanted to look at some of its functions beforehand. We're going to look at some of the functions here of the gastrointestinal tract and basically identify 6 or 7 things that happen within the digestive system. So ingestion is what we call putting things into your mouth. So you're going to ingest food or ingest medicines or ingest water. Then we have 2 kinds of digestion. And it's important, especially when you get to physiology, to kind of keep these 2 types of digestion separate. Mechanical digestion is really just breaking up large pieces of food into smaller pieces of food. It's not really technically digestion, it's just breaking apart. But we term it mechanical digestion because there is no chemical change that's occurring. We're not breaking down larger chemicals into smaller chemicals. We're just breaking down our chunks of food into smaller chunks of food. So in the mouth, this happens with our teeth and gums, and I think that's easy to understand. But when we get to the stomach and the intestines, we're going to see that there is still some mechanical digestion happening there just by the sloshing around of food particles as they move back and forth and the muscles of those parts of the tube contract. It will continue to break up large pieces of food into smaller pieces of food. So that's mechanical digestion. Then we have chemical digestion, and this is really true digestion, where you're going to take food and break it down from its larger molecular parts, let's say a carbohydrate, a complex carbohydrate, for example, and you're going to break it down into absorbable small portions, small molecules. So you might take a complex carbohydrate like pasta or potato or bread, and you're going to break it down into something that's actually absorbable, like a monosaccharide, like a glucose or fructose or something like that. Chemical digestion is going to require typically some kind of enzyme to help break that down before it can be absorbed. Okay, so those I think we pretty much get. Secretion is another function, just because there are several liquids and enzymes and other molecules that are secreted along the digestive system and through some of its accessory organs that are necessary either to protect the gastrointestinal tract, to help aid in digestion, to help break down food, to help with motility. All of these things have to be produced in epithelial cells within the gastrointestinal system and then secreted into the tract in order to help aid in digestion. And we'll talk about some of those as we go along. Then once you kind of break down the food, you need to absorb the food. So that's the next function. If we're not able to absorb certain nutrients, then we will become deficient in those nutrients. And when you guys get to pathophysiology, you'll learn about several diseases of absorption. The most, I think, well-known one is celiac disease, where people are not able to absorb gluten, and it ends up causing quite a bit of difficulty within their gastrointestinal system. So Our GIT tract also functions to absorb nutrients, and what you'll learn in physiology is that there are certain nutrients are absorbed only in particular sections of the gastrointestinal tract. Most of it is going to occur in the small intestine, with the exception of fluids and some electrolytes, which are also absorbed in the large intestine. Okay, once you've absorbed the material that you want to keep, there's still the issue of getting rid of the material that you can't use, the material that is waste product. And so that takes two processes really. One is compaction, that's taking all the small undigested bits of food and whatever you've eaten and kind of compressing it together into something that can be removed from the body. So you're going to get it compressed, you're going to remove fluid from it so that you don't waste fluid that your body needs. That's compaction, and then eventually you're going to excrete that waste product in terms of feces. We call that excretion defecation. The liver does have something to do with kind of getting rid of substances that maybe are harmful to the body or substances that we don't need. And we'll talk a little bit more about that in physiology, but it's listed here under excretion just because it aids in getting rid of unwanted molecules that may enter the body. And so then those also get modified in the liver, and they get excreted into the GI tract, and then eventually they end up in your feces. Okay, so let's take a look at the histology, meaning at the tissue level, what does the gastrointestinal tract look like? And what we're going to find is pretty much along the whole tract, we have 4 layers. Now, in a couple of places, the names of these layers may change, but you're still going to pretty much have these 4 layers along the GIT, with the exception of the rectum and anus. So the 4 layers are the mucosa, the submucosa, the muscle layer, and the serosa. So if we start from the inside out, this would be inside, and this would be out. So the very inner layer is called mucosa. It's a very thin epithelial layer, kind of a sheet of moist epithelial tissue. The easiest way is to just rub your tongue around the inside of your mouth, and you'll feel how it's kind of slippery and wet. That's the mucosa that you're touching with your tongue, and that kind of same type of thin, slippery, wet tissue layer pretty much goes all the way to the rectum. Underneath that, you have the next layer, which is called the submucosa. Remember, sub means underneath, like a submarine, right? It submerges, it goes underneath. So mucosa on the inside. The inside, by the way, this kind of hole on the inside, the inside of the tube, we call that the lumen. So the part that's closest to the lumen is the mucosa. Just deep to the mucosa will be the submucosa, which is, I think, should be easy to remember. Then you have a muscle layer composed of 2 layers of muscle, and then the serosa is what is on the outside. So for example, if you have a chance to go into abdominal surgery, and the surgeon opens up the belly and you take a look inside and you see the intestines from the outside, what you're looking at there would be the serosa. So let's take a look at some of these other kind of structures within different parts of the bowel that aid in some of the functions. So another structure that you'll find in different places in the stomach, in the small intestine, for example, you'll find these circular folds. And it's kind of like the bowel is accordioned a little bit. And so there's parts of it that are kind of folded up. You can kind of see the circular folds in here. And really they just function to help increase surface area for the absorption of nutrients. Another kind of strategy to help with increasing surface area for the sake of increasing absorption is the villi that you'll see. So here on this picture, this is kind of showing you one circular fold. So it's showing you kind of one of these. Oh, it's showing you this one here. And then even with on top of the circular fold, you have more kind of folds, hills and valleys. These are the villi. And we talked about these way back in the intracellular anatomy chapter, if you remember. And they're basically just formed by the cytoskeleton of the cells there, and they help kind of push out part of the cell membrane of that cell in order to increase surface area so that you can absorb more nutrients. And we'll talk about that more when we get to physiology. Okay. And then what we're going to find is on top of those villi, you have even more villi, smaller villi on top of the villi, and we call those microvilli. So you have villi, and then you have microvilli, which we'll see later in another picture. Okay, if you look, again, deep to the mucosa, where the villi and microvilli are, you'll find the submucosa. That's the layer that has the blood vessels, for example, something called lacteals, this green thing, part of the lymphatic system that helps us absorb fats. And then if you go deep to the submucosa, you'll find two layers of muscle. There's a circular layer and a longitudinal layer, and we'll meet those here again in a minute. And then the serosa is kind of the outer layer. All right, so if we look at the mucosa, we will often call the mucosa a mucous membrane. A membrane just means something that covers, right? And mucus is just what it sounds like. There are mucus components to kind of the surface of the mucosa. That's why in your mouth, for example, when you rub your tongue around, it feels kind of slippery. This is why saliva is it's not just wet, it's sticky. If you've ever noticed, my son does this because he plays football, but he will put spit on his gloves, his receiver gloves, and then kind of rub them around, and when they dry, they make his gloves a little bit more sticky. That's the mucus element in the saliva that makes it a little bit sticky. It is composed of epithelium, so remember we talked about 4 types of tissue: epithelium, connective tissue, muscle tissue, nervous tissue. So this is epithelial tissue. We talked about those circular folds. Another word for that is plicae circularis. You might see that word as well. And as we mentioned, they allow for increased surface area as well as for some folding and stretching, which aids in mechanical digestion, kind of like an accordion going in and out. The lamina propria would be what is kind of holding the mucosal layer to the submucosal layer, and then we talked about the villi already. Okay, then if we move down to the submucosa, as I mentioned, it's where the nerves, arteries, and veins are located. Now this is not epithelial tissue, this is now connective tissue, and it's going to connect that epithelial layer of mucosa to the muscular layer below it. Sometimes it's going to secrete some buffers or enzymes, although most of the time those secretions will come from the epithelial mucosal layer. As we continue to go deep in our layers, we meet the third layer, which is the muscle layer, and within the muscle layer there's typically 2 kinds of muscle. We'll see in the stomach there's actually 3 kinds, but for most of the gastrointestinal tract we'll find these 2 layers. A circular layer, which when it contracts, it kind of squeezes. If you imagine a big circle becoming a smaller circle, much like orbicularis oris and orbicularis oculi, that when they contract, it causes the lumen to get smaller. So that's going to squeeze the bowel. And then a layer of longitudinal muscle underneath that, which makes the bowel move back and forth more like the accordion type movement. And so you want both in order to mechanically digest food, as well as propel food forward in the right direction so that it can be absorbed and then eventually excreted. So you need both of these layers of muscle. Now this muscle is controlled by its own autonomic system. So we've talked about the sympathetic and the parasympathetic system, and they are still active here at the gut, but the gut also has its own autonomic system called the enteric nervous system. And again, we may get into that in physiology. As for sympathetic and parasympathetic, you should know this already from the nervous system chapter, but parasympathetic is going to increase gastrointestinal motility, or the movement within the gastrointestinal tract. Sympathetic stimulation is going to reduce that or slow that down. That's why we say parasympathetic is rest and digest, because part of digestion is movement of the bowel so that you can move food in the right direction. The serosa is just going to be kind of that outside layer. Again, if you opened up an abdomen and looked inside at the bowel, you would be looking at the serosa, and typically it's attached to other membranes to kind of hold the bowel in place. We're going to talk about the mesentery. The mesentery is typically attached to the serosa to kind of hold the bowel in place, and so we'll talk about that when we get a little further on in the lecture. The serosa is missing in a few places, so there are a few places that really only have 3 layers. I already mentioned the rectum earlier. It's also absent in the pharynx and the esophagus, which are largely muscular. In there, we have something called adventitia, which kind of takes the place of the serosa, and its makeup is just a little bit different, so we give it a different name. All right, so if we're talking about the gastrointestinal tract, most of that is contained within the abdomen, with the exception of mouth and esophagus. So the abdominal portion of the gastrointestinal tract, for the most part, is contained within what we call the peritoneal cavity. So to help understand what this means, I want you to think back to when we were talking about the lungs, and we were talking about the lungs were in the thorax, which is the chest, and there was a pleural cavity, so to speak, between the lungs and the wall of the inside of the chest, right? The kind of the backside of the ribs. And there was a lining that lined the lungs. We called that the visceral pleura. And then there was a lining that lined the wall of the chest cavity, the inner chest cavity, and we call that the parietal pleura. Well, there's a similar double layer occurring in the abdomen. There's a layer of kind of thin connective tissue that separates the contents of the abdomen from the abdominal wall itself. And so when it was in the lungs, we called that the pleura. When we had that double layer in the heart, we called it pericardium. And now we have a similar double layer in the abdomen, and we give it a different name called the peritoneum. So the peritoneum in the abdomen is analogous to the pericardium in the heart and the pleura in the chest. All right, so the visceral peritoneum is going to be the layer that is covering the actual bowel and the other organs within the peritoneal cavity. So when we're talking about the gastrointestinal tract, that layer is actually the serosa. So the serosa of the gastrointestinal tract acts as the visceral peritoneum. They're one and the same. The parietal peritoneum is what is the other layer that is kind of on the inside of the abdominal cavity, and they are it's important kind of for anchoring the gastrointestinal tract to the abdominal wall, so that in general, I mean, it's kind of flexible and loose, but in general, our bowels stay in the same location because of this peritoneal membrane that holds everything in place. Okay, so a lot of the organs, most of the abdomen is going to be contained within this peritoneal cavity, but there are a few structures, parts of intestine, and a couple of organs that are actually behind the peritoneal cavity and not actually located within the peritoneal cavity. So to help see that, this is a good picture here from kind of a side view, a sagittal section, where we can see the peritoneum, and then we can see what's within the peritoneum, and we can see what is behind the peritoneum. So the peritoneum is this kind of white outer double layer that you see. So it wraps all the way around. This pink thing is the diaphragm. So it's gonna, starting under the diaphragm, you can see. But notice when we get to the pancreas, it does not enclose the pancreas. It actually goes anterior to the pancreas. So the pancreas is not within this space. It's actually behind the space. And as we continue to look at the peritoneum, we'll find other pieces. Oh, look, this part of the small intestine called the duodenum is also not within the peritoneal cavity. It's actually behind the peritoneal cavity. And as we go along, we see most of the intestines are in there, most of the colon is in there, until we get to the rectum, and then we see once again the rectum is behind the peritoneal cavity, as well as some of the female organs and bladder. So these ones that are behind, the pancreas, for example, the duodenum, there's a couple of portions of large intestine, the rectum, we call those retroperitoneal. So we're talking about retro means back, right, behind. If we say like your style is retro, we mean it's from 30 years ago. You went back in time to get your style. And so these organs are back, all right, towards the back behind the peritoneal cavity. So we call them retroperitoneal organs, or the retroperitoneal space. And you're gonna see this clearly when you dissect your pigs. You'll be able to see, because you'll actually have to cut through the peritoneum twice. You'll have to cut through it anteriorly in order to get into the peritoneal cavity and see all the intestines and stomach and all that. But if you want to get behind that and see, for example, the kidneys, which are also retroperitoneal, you're going to have to cut through the backside of the peritoneum in order to expose the kidneys. So you'll be able to see exactly what this layer and what these cavities look like. Kidneys, ureters, abdominal aorta is also retroperitoneal, for example. All right. Speaking of peritoneum, there are certain portions of the peritoneum that are kind of thicker. They contain some more connective tissue, and they really provide some structure and support for the intra-abdominal organs. Without these layers, they would just be kind of free floating in the abdomen, and they would be moving all around, more susceptible to twisting and getting out of place. So the peritoneal layer or lining in some places becomes a bit more substantial, and it functions to kind of hold things in place. And in those areas, we call that part of the peritoneum, we call it mesentery or omentum. So mesentery are sheets of connective tissue that kind of connect the visceral and parietal membranes of the peritoneum, like we were talking about. And mesenteries can occur kind of anywhere. When they occur in a large chunk together, we call that omentum. So omentum is just a type of mesentery, kind of a large mesentery would be considered an omentum. And there's a couple of important ones in the abdomen. The biggest one is this large omentum here that kind of goes from the inferior aspect of the stomach, and it covers all of the intestines. And so, for example, when you're watching an abdominal surgery, you have to get through that omentum before you can get into the peritoneal cavity, because it kind of sits on top. All right, now let's begin our discussion of the tract going from the mouth, and then we will end ourselves at the rectum and anus. So the mouth we call the oral cavity. There is oral mucosa there that I already had you feel with your tongue, and that is non-keratinized stratified squamous epithelium. So it's similar to the skin on the surface of your body, which is also stratified squamous epithelium, but there's no keratin. The keratin is what gives our skin its toughness. This is why you can more easily scratch the inside of your mouth, for example, chewing on a potato chip, than you can scratching the palms of your hands, which have a lot of keratin. And then, of course, the gums are just ridges of oral mucosa. Within the oral cavity, there are several ducts that carry saliva that's made in multiple salivary glands, and the saliva becomes important for digestion. Saliva is mostly water, 99.4%, and so its biggest function is just to moisten food. But it also contains some buffers to help with things that are too acidic. It has enzymes such as amylase, which help us break down, do a little bit of chemical digestion. Amylase, for example, helps us to digest carbohydrates, and so the beginning of carbohydrate chemical digestion actually occurs right in the mouth. There are three primary salivary glands. The parotid, which is kind of just overlies the ramus of the mandible, just anterior to your ear. Then there is the submandibular gland, which is kind of under the angle of your jaw, the angle of the mandible, a little bit anterior and underneath. And then you have sublingual, which are underneath the tongue. Typically, when someone feels their throat and they say, "Oh, my glands are swollen," they're talking about this area. It's not usually their glands that are swollen, though. It's usually a lymph node. But the submandibular gland is very close to some of the lymph nodes there in the neck. The submandibular gland is the primary producer of saliva, producing about 70%. All right, if we move back from the mouth, we'll enter what you would call the throat. Anatomically speaking, that's called the pharynx, and we mentioned this in the respiratory tract. There are 3 sections of the pharynx. The section behind the nose is the nasopharynx. The section behind the mouth, if you have someone open their mouth and say, "ah," the part that you're seeing is the oropharynx. And then there's the lower part of the pharynx that kind of leads to the larynx and to the esophagus, and we call that the laryngopharynx. If we move down from the pharynx, we get to the esophagus. The esophagus is basically a muscular tube. Its primary function is to move food from your pharynx down into your stomach, and it does that through a rhythmic contraction of the muscle that we call peristalsis. There are 2 sphincters within the esophagus. Remember, sphincters are a circular muscle, and when those circular muscles contract, they close off the opening, and when those circular muscles relax, they open the opening. And so there is one at the top of the esophagus to allow food to pass from the pharynx into the esophagus. So that sphincter has to open when we swallow to allow food to go from the pharynx into the esophagus. And then as the food travels down the esophagus, it gets to the connection of the esophagus to the stomach. There's another sphincter muscle there, and that sphincter muscle also has to relax and open to allow the food to enter the stomach. Now, what's important about that lower esophageal sphincter is that if it is loose or it's not very strong or tight anymore, acid and food particles that are in the stomach will reflux up into the esophagus and cause heartburn at the least, or it may even cause erosion along the mucosa of the esophagus and cause something called esophagitis. There is even some evidence that long-term reflux that's more severe may lead to esophageal cancer. So a lot of people who suffer from reflux, esophageal reflux disease, or we call GERD, for many of them, the primary problem is that this sphincter is no longer tight. It's become loosened, and so that becomes a difficult thing to treat. We do start treatment with antacids, which help with the pain and reduce the acid, but it often doesn't reduce the reflux. Okay, the other thing to know about the esophagus is that it's very posterior. It's towards the spine. It's actually between the trachea and the spine, so it's posterior to the trachea. It's quite deep. The other thing I had mentioned in the respiratory chapter is that its default position is closed. It really only opens when you swallow. And then there has to be a little hole in the diaphragm to allow the esophagus to move from the thoracic cavity into the abdominal cavity where it connects with the stomach. And we call that the esophageal hiatus. And sometimes that hole also gets enlarged, and the stomach begins to move up through that hole, and we call that a hiatal hernia. And it comes from that term, esophageal hiatus. Okay, swallowing occurs in several phases. The buccal phase, remember buccal means cheek. You learned about the buccinator muscle there. The mucosa on the inside of your cheek we call the buccal mucosa, and this phase that occurs in the mouth we call the buccal phase. Basically, it's chewing, what we call mastication, breaking up the food into smaller pieces, mixing it with the saliva in your mouth, and forming it into a little ball of food that we call a bolus. Next is the pharyngeal phase, where you push that to the back of your throat. The voice box or larynx elevates in order to kind of help prevent the movement of that food into the trachea, which you would not want. That would be aspiration. That's a bad thing. And of course, the epiglottis here, as that food pushes on it, it folds over and protects the trachea, which is anterior, the larynx. And that food ends up sliding posterior to the larynx and ends up in the esophagus, which is the next phase. In the esophagus, you have peristalsis, which is rhythmic contraction of the muscles, which pushes that bolus of food down into the stomach. The stomach itself has 4 regions that you need to be aware of. The cardia is the superior and medial aspect. It's the part that connects to the esophagus, so that part there we're going to call the cardia of the stomach. Then there's the fundus. You're going to find this term fundus kind of always means the top part. The fundus of the uterus, for example, is the most superior part. The fundus of the stomach here is this superior section. Then the body is really most of the stomach, and the final section of the stomach that attaches to the small intestine, this section here, is called the pylorus. And it's divided into its own sections, which I'm really not going to make you memorize, but within the pylorus there are even more smaller sections. There are 3 layers of muscle here instead of just the typical 2 that we talked about. You still have the circular muscle and you still have the longitudinal muscle, but you also have a layer of oblique muscle. And that's because the stomach is really heavily involved in mechanical digestion of food, and so it requires that 3rd layer of muscle to help move the stomach in multiple directions, really slosh that food around back and forth, bang it against the sides of the inside wall of the stomach and help break it apart. So whatever doesn't get broken up in your mouth typically gets broken up here in the stomach. You can see the 4 sections here again. Okay, if we look down at the tissue level of the stomach, it gets a little more complicated. We're just going to kind of give you an introduction here in anatomy. When you get to physiology, you'll talk a bit more about the different types of epithelial cells that are there in the stomach and the different substances that they produce. The mucosal layer is composed of simple columnar epithelium. So remember, the inside of the mouth was stratified squamous. When we get to the stomach, we're talking about simple columnar, and that's because a lot of them are going to be involved in producing and secreting substances, whether it's mucus or acid or enzymes. And if you remember from the epithelial tissue lecture, we talked about how epithelia that are producing and secreting, they tend to be columnar or sometimes cuboidal. So here, the structure fits the function again. We have simple columnar. The surface epithelia, the epithelia right on the inner side of the stomach, needs to be protected from the acid which the stomach itself produces. And it does that by secreting mucus. And we'll talk more about that in physiology. But there's a mucus layer that's secreted by these epithelial cells, by some of the cells, that help to protect that innermost layer. The deeper epithelial cells, the ones that kind of go down into the pits here, so these more surface ones are producing the mucus that helps protect. But deeper, there's multiple types of epithelial cells, and I'm going to just mention 3 of them here. You'll learn more in physiology. There's a type of epithelial cell down in the pits that's called parietal cells, and these are the ones that are responsible for producing hydrochloric acid, the acid that helps us digest our food, the acid that makes our stomach acidic. It also secretes something called intrinsic factor, which is needed to absorb vitamin B12. There are something called G cells. G cells are easy to remember. They produce gastrin. And gastrin is kind of like a local hormone in the gastrointestinal system. And it's produced by G cells, so G for gastrin. And then chief cells produce pepsinogen, which is used to help break down, digest proteins. Kind of got cut off there. So protein digestion. So starch digestion begins in the mouth. Protein digestion begins in the stomach. So if we kind of get a blow-up picture of a gastric pit, you can see here we've got these mucus cells here closer to the surface to help kind of produce mucus to protect the inner surface of the stomach. And then as we go down in the pits, we find things like parietal cells, G cells, chief cells, all in there producing their various molecules. And there's even more that you'll learn in physiology. All right, as we move on from the stomach is attached to the small intestine. The small intestine is composed of 3 sections. So the first part of the small intestine that connects to the stomach is called the duodenum, and I'll just mention that now. We'll see the other ones in a minute. Duodenum, or as the British say, the duodenum. So the duodenum is the first part of the small intestine that attaches the pylorus of the stomach to the small intestine. The small intestine is really important because it's where most of our absorption happens. So if we break down all of our food into its component parts, that's great. But if we don't absorb those component parts, if we don't find a way to get the glucose and the fructose and the amino acids and the lipids and the glycerides and all those, if we don't find a way to get those molecules from the lumen of the gastrointestinal tract into our blood supply, then we cannot take advantage of any of those nutrients. So those nutrients have to be absorbed. They have to move from the inside of the gastrointestinal tract, and they have to move into the blood supply. And that's called absorption. And that absorption occurs almost completely, 90%, in the small intestine. So it's really important to understand that. The small intestine is quite long, 20 feet long, and it connects the stomach to the large intestine. There are small ring-shaped projections. Remember we talked about the circular folds? This is where you're going to see them a lot in the small intestine, and they're called plicae circularis, as I mentioned earlier. So those are very prominent here in the small intestine. The villi we talked about in addition to the circular folds, and even the microvilli, even villi on top of villi, to help increase the surface area available within the small intestine, because the primary function is absorption. And the more surface area you have, the more nutrients can be absorbed. So structurally, the small intestine is full of tricks to help increase the surface area for the purpose of increasing absorption. Okay, so here's the 3 regions that I mentioned. The blue region there, kind of the shortest of the regions, connects the stomach, which would be here. That's the duodenum, the blue one. And then you see the jejunum is the kind of section in the middle, is kind of this purple color. And the ileum is the final part of the small intestine, and eventually connects the large intestine here with the small intestine there. Just to kind of give you a look at what this would look like grossly, if you could look inside the small intestine, you would see that each of those 3 regions, although there's a lot of similarities, and that's why we call them all small intestine, they're slightly different when you look at them. If you take a look at the circular folds, some of them may be more or less depending on which part of the small intestine you're in. So here we're looking at the duodenum cut open, and here's the jejunum, and here's the ileum, and there's just some mild differences there. We do have our 4 layers, as always. We have the mucosa and the submucosa and the muscular and the serosa, and you can see these circular folds here and the villi. There's something else I wanted to mention, just so you're aware of the term. Peyer's patches are kind of like bunches or concentrated areas of lymph tissue, of immune tissue. And this is really important because our gastrointestinal tract is really open to the external environment. Things can get in our mouth that may be harmful to us. And if they happen to get past the antibodies in the mouth, and they happen to get past the acid in the stomach, and they end up in the intestines, they might get absorbed into our blood supply along with the nutrients. So all along the small intestine, you will find something called Peyer's patches, which you're kind of seeing here in the picture, are these clumps here. of immune tissue, immune cells that are kind of to be the first line of defense in the small intestine in case any bad things made it through. Okay, that leads us to the large intestine. Another name for large intestine is bowel, or large bowel, or colon. You'll hear colon used a lot, so I would make sure that you learn the term colon along with large intestine. I once had a professor in medical school, or maybe it was residency. No, I think it was medical school. And he said, the colon is really a social organ. And we said, what do you mean by social organ? And he said, well, your colon basically, its main function is to absorb fluid. It's to kind of make you have stool or feces that is not runny, that is not watery. It absorbs the excess water to give you formed stools. He said without the colon, the stool, the feces would be so wet that when it left the intestine, it would just run right out, and you would have to go to the bathroom every 30 minutes, getting rid of all of that liquid stool. You'd have chronic diarrhea without your colon. So the colon's primary job as a social organ, he would say, is to allow you to play sports for 2 or 3 hours and not have to go to the bathroom, or have a conversation with people, or even sit through class without having to use the bathroom. Because the colon is absorbing all that excess fluid, it's really more than just a social organ. That it's important that it absorbs that fluid, because you would lose a lot of water, and then you would have to drink a lot more water to make up for that, or you would become dehydrated. So more than just allowing you to sit through class or play a sport, absorption of water is important to prevent dehydration. So your colon largely functions to reabsorb water. Along with that water, it's also reabsorbing some electrolytes like sodium, potassium, magnesium. So just like the small intestine had 3 sections, the large intestine or colon also has 3 sections. We call the end here, the part that attaches to the ileum, we call that the cecum. We call the rest of the large intestine the colon, and then the rectum is the part that kind of stores feces until you're ready to get rid of it. We're going to find, when we talk about the colon itself actually has 4 parts. So after the cecum, we get the ascending colon, because food is going from the ileum into the cecum and then up the ascending colon. So we call it ascending because it's moving up. Once it gets to this flexure, this bend that we call the hepatic flexure, because your liver is sitting over here. So the hepatic flexure, then it becomes the transverse colon. Remember, transverse means horizontal. And then after, the spleen is going to sit over here. So we call this the splenic flexure. It's the bend around the spleen. And so after the splenic flexure, it becomes the descending colon, because the feces are now going down, descending. And then we get to this kind of S-shaped portion, which we're going to call the sigmoid colon, which comes from the S shape. And then that's going to lead into the rectum. Now the wall of the colon is, you might notice, is kind of broken up into these rectangular sections. And these rectangular sections are called haustra. And so we don't have plicae there are still some folds in there, like the plicae circularis, but what's more prominent in the colon are these haustra folds, which you can see through the cutout there. And that's going to be helpful when we look at an x-ray of the colon and the small intestine to help us differentiate colon from small intestine on an x-ray, and we'll see that here in just a minute. So if we take a look here at an abdominal x-ray, sometimes we call this a flat plate or a KUB. That A should be up there. Sometimes when I convert these, the writing gets a little mixed up. So we want to be able to look at plicae circularis, which we talked about earlier in the small intestine, and haustra, which are much more prominent in the large intestine. And we can use those 2 anatomical structures to help us determine what we're looking at on an abdominal x-ray. Are we looking at large intestine or small intestine? Now normally on a normally on an abdominal x-ray, if everything's okay, you really should only see air in the large intestine. You really shouldn't even be able to see the small intestine. We can only see the parts of the bowel that contain air, because otherwise the x-rays kind of are equally absorbed, and we can't really see any definition. So any definition to the bowel on an x-ray is going to be because there's air present. And remember, on an x-ray, air looks dark because the x-rays go right through the air and hit the plate. So whenever we see black, that's going to be air. So notice all this, you can kind of get the sense that there's something here, right? And maybe it goes here, and there's something here, because you can see the dark. Notice, if we blow that up, notice these kind of very narrow, close together lines that are going all the way across from one end of that tube to the other. Those are plicae circularis. We actually should not be able to see that, because that means there is a small bowel that's full of air, and there shouldn't be really air, that much air visible in the small intestine. Now, just by way of contrast, take a look at, let's say, this kind of tube up here. Notice you've got more like rectangles. You see that? Larger sections. That's going to be the haustra of the large intestine. So that's okay. Up here you've got hepatic flexure, you've got transverse colon. This bubble here is probably in the stomach. And so you're supposed to see air in the large intestine, that's normal, but you should not see so much air in the small intestine like we see on this picture. This patient probably has a bowel obstruction, and so the air and the stool is backing up into the small intestine, and you can see it. So haustra on the large intestine and plicae circularis on the small intestine. All right, let's take a look at some of the accessory organs. We have the liver. The liver sits in the right upper quadrant of the abdomen, just at that hepatic flexure of the colon, as we mentioned. And the liver is separated into 4 lobes. 3 of them you can see here on this anterior view. And you have to kind of look at the posterior view to see the 4th lobe. I'm not going to make you learn the names of the lobes. Some of them are easy, like right and left. Some of the other couple have stranger names that are that you don't really have to worry about for this course. Just know that there are multiple lobes of the liver. Right and left are the kind of most important ones that you hear people talk about the most. And there are multiple ligaments that separate the liver into those lobes. It is the largest solid organ, or sometimes we call it visceral organ. So the gastrointestinal tract, like the small intestine, may be 20 feet long, but it's not a solid organ. It's hollow, right? It's got a tube. It's a tube. So the largest solid organ is the liver. What we'll find when we look at the backside, we'll find the gallbladder kind of attached posteriorly and inferiorly, usually off the right lobe or just in between the right and left lobe of the liver. So if we turn the liver and look posteriorly, now you can see this other lobe here called the caudate lobe. And you can still see the right and left, and then down here you can see the quadrate lobe. You don't have to memorize caudate or quadrate, but just be aware that there's 4 lobes of the liver. The right lobe is the largest, and then the left lobe would be the next largest. And again, you can see the ligaments kind of separating those areas. Now that we're looking posteriorly, you can see all of the gallbladder, right? Because the gallbladder kind of sticks to the posterior side of the right lobe, and it's usually pretty close to the right and left lobe, or the right lobe and the quadrate lobe, and it's inferior. It's on the lower aspect of the liver. Okay, so we talked about this a little bit in the circulatory system, but remember there's a portal vein that takes all, remember we were talking about the food that's in the lumen of the intestine. It needs to be absorbed through the wall of the intestine and into the blood supply. Well, that blood supply feeds all of everything that was absorbed. So nutrients, fats, proteins, glucose, as well as any substances like drugs. Let's say you took penicillin, or let's say you took blood pressure medicine, or let's say you took cocaine or heroin or whatever. All of those substances that get absorbed, they go into the portal vein, and the portal vein brings it first to the liver. And that's because the liver is, one of its functions is to help us to start metabolism of some of those substances, store excess substances, so excess sugar, for example, glucose, gets stored in the liver as glycogen. But it also helps us kind of break down and deactivate substances that are foreign, so drugs, for example, or toxins or poisons. They will also go to the liver first and be kind of broken down so that they can hopefully be less toxic to our system. Then the hepatic veins we talked about. So that's the portal vein, which isn't really shown. Oh, there it is. And here's portal vein. That's kind of a branch of the portal vein. And then there's a hepatic vein, of course, that drains all the used up blood from the liver, and it drains it directly into the vena cava. We talked about that in the circulatory system. So there's an area on the posterior aspect of the liver, kind of right in between the right, left, and quadrate lobes there. This area here is called the porta hepatis. Think of like the port of Los Angeles or the port of Baltimore, right? That's kind of like a place where lots of ships come in and out, and they kind of harbor and they load and unload. So the porta hepatis is kind of like the loading and unloading portion of the liver. It's where the portal vein comes in. It's where the hepatic artery comes in. It's where the bile duct for the gallbladder comes in. So they all kind of congregate in this one area called the porta hepatis. So there are multiple functions of the liver, and I put this table in here just so that you can be amazed at all the functions of the liver. And then I wrote here on this side the ones that I really want you to think about. So it does make bile. Bile is stored in the gallbladder and then excreted into the intestines whenever we eat a fatty meal to help us digest fats. It does store glucose in the form of glycogen. So glucose are kind of simple molecules, and they can be combined together to make more complex molecules for storage of that glucose for later use when we might need energy, and that larger molecule is called glycogen. It also inactivates toxins, which I've already mentioned. It stores iron, which is important. So we don't necessarily have to consume a lot of iron every day, as long as we get enough iron, let's say, in a week. Any excess iron can be stored in the liver and then kind of given back into the blood as needed. It helps to make certain proteins that are important in the blood. If you remember, in the blood chapter, we talked about albumin as being one of the primary proteins that's in the blood. That albumin, for example, is made in the liver. It also produces clotting factors to help us make clots and stop bleeding. And so whenever somebody has damage to the liver, let's say you have an alcoholic who's been drinking for 30 years heavily, and he's damaged his liver, he has cirrhosis. One of the things you'll notice is easy bruising, easy bleeding, and bleeding that takes a long time to stop. And that's because the dead parts of the liver can no longer produce clotting factors that we need in order to stop bleeding. All right, the gallbladder I already mentioned a little bit. The gallbladder is really just a muscular sac. So the liver is what's actually making the bile, which is a substance that helps break down large fats into small fats. We'll talk more about that in physiology. For now, just think of it as being involved in fat digestion. And so the liver makes the bile. It's actually the cells in the liver that make it. But then they secrete all of that bile into tubes and ducts, which eventually make their way to the gallbladder. And so the gallbladder becomes just a holding sac for bile. And then when you have a fatty meal, certain hormones are produced which cause that gallbladder to contract, and they squirt that bile out and down into the intestine. There are 3 sections to the gallbladder. The fundus, we've already kind of mentioned, is always going to be kind of the rounded superior most part. And then we have the neck. So this is going to be the fundus. Then the neck is going to be here right as it connects to the common bile duct. And then everything in between is the body. So from the neck down to the duodenum is a duct that carries the bile, and we call that the common bile duct. So there's kind of 2 ducts here to remember. So the one that carries bile from the gallbladder to the small intestine, to the duodenum, that's the common bile duct. the one that carries bile from the liver to the gallbladder, that's called the cystic duct. Then the opening where the the common bile duct empties bile in the duodenum, you can kind of see that little circle there. That's a sphincter muscle, and it's called the sphincter of Oddi, or the hole is called the ampulla of Vater. Nowadays, we like to call this hole, instead of the ampulla of Vater, we call it the hepatopancreatic ampulla, which actually makes more sense because it kind of tells you, where the tubes are coming from. So notice this opening, this ampulla, has two ducts that lead into it, right? You've got the bile duct that we've been talking about, but you also have the pancreatic duct, which we're going to talk about in a minute. And both of them empty their fluids into this ampulla, this hole, so that they can go into the small intestine, the duodenum, and aid in digestion. Well, the problem is if you get a stone in the gallbladder, let's say you get a gallbladder stone, a gallstone, and that stone makes its way through the neck and down the common bile duct and right there to the sphincter of Oddi at the hepatopancreatic ampulla. So let's say now you get a stone stuck here. And it gets stuck because this opening is so small, it's really hard, especially if it's a bigger stone, to pass through that small ampulla, that small opening. So now what happens is you get a backup of bile that ends up going back up into the gallbladder and can even back up into the liver if the gallbladder gets overfilled. And you can get kind of dilation of those ducts in the liver and can eventually even do damage to the liver if it's there long enough. But you also get backup of pancreatic juices, which we'll talk about in a minute. And a lot of those are actually caustic to the pancreas. So if you get backup of that fluid back into the pancreas, it begins to almost digest the pancreas. And you get something called pancreatitis, which really just means inflammation of the pancreas. So a gallstone commonly gets stuck here at the ampulla, at the hepatopancreatic ampulla, has a tendency to cause pancreatitis. And so, in fact, when a patient comes in with pancreatitis, the most common cause is a gallstone. And so we will actually do tests to look for a gallstone. The second most common cause is too much alcohol. And so we'll also ask a history of alcohol use. Okay, and lastly here, we'll take a look at the last accessory organ that we're going to mention, which is the pancreas. So the pancreas is located posterior or deep to the stomach. So the stomach, you can see, sits on top of the most of the pancreas. And again, you'll see this when you cut open your pigs. You're going to have to go very deep and go behind the stomach. You're going to have to lift the stomach up to find it. And remember, the pancreas is posterior to the peritoneal cavity. So you're actually going to have to cut through that peritoneum, that thin layer of connective tissue, in order to see the pancreas fully. So the pancreas is retroperitoneal, sitting behind the stomach. It is also composed of three sections. There is the tail, which you should be able to recognize here. There is the head, which is going to be this kind of circular portion on the other side. And then the body is going to be everything in between. And remember that there's a duct that runs through the middle of that because the pancreas is producing a lot of enzymes, bicarbonate, and some other juices that flow through that duct and eventually get emptied into the duodenum where they can aid in digestion. That's one of the primary functions of the pancreas, is to help aid in digestion in the small intestine. And that pancreatic duct is essential for that because all of the cells that are producing enzymes and bicarbonate, they get poured into that duct, and that duct then empties into the duodenum. So there are two types of functions of the pancreas. You remember when we looked at the endocrine chapter, we talked about the endocrine function of the pancreas, and we said it was only really 1% of the cells in the pancreas were producing hormones, and we talked about insulin and glucagon that kind of aid with glucose absorption and storage. So the other 99% is exocrine function, meaning the cells secrete something kind of into the external environment. So for example, the submandibular gland, the parotid gland we talked about that produce saliva, those are exocrine glands. They produce a substance, saliva, and they secrete it into the external environment of the mouth. Well, here you've got 99% of the pancreas is producing enzymes used for digestion or bicarbonate to help neutralize the stomach acid that enters the duodenum. And it's going to secrete those into the pancreatic duct and eventually into the intestine, which is really the external environment, because the lumen of the intestine is kind of eventually open at the mouth or open at the anus to the external environment. So we call that exocrine function. It produces enzymes for fats, for example. Those are called lipases. Enzymes for proteins, those are called peptidases. And enzymes for carbohydrates, those are called amylases. So we mentioned that carbohydrate digestion begins in the mouth, but it really gets most of it happens in the small intestine because of the amylases coming from the pancreas. We mentioned that there were peptidases in the stomach to help begin the digestion of proteins in the stomach, and that's true, but most of the digestion of proteins occurs in the small intestine from peptidases secreted by the pancreas. So if you end up having damage to your pancreas that's significant, a lot of times those people will have to actually take these enzymes through a pill form every time they eat. Otherwise, they won't be able to digest the food that they consume. All right, a lot of this we will actually see when we cut open the pig. So that's really going to be our practical hands-on lab. And so we won't have a lab specifically for this, but when we do our pig dissection, you'll be able to see a lot of these structures at that time.